طيب بسم الله الرحمن الرحيم. السلام عليكم. I'm Dr. Taysir Al-Taib. I'm so happy to be with you and more happy that you are with us tonight at this wonderful session, inshallah, beating the best current pharmacological meditations for treatment of COVID-19 infection with Professor Imad Salah Hassan. He's MD Immunology from UK and has a master degree in infectious diseases, head section of medical protocol department, King Abdulaziz Medical City, Riyadh, Kingdom of Saudi Arabia. I promise you this session will be an interesting session as usual with our unique Professor Imad. Professor Imad, the floor is yours. تفضل يا بروف.
طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله ومشكورين الجميع على الحضور. This is a very serious session. It's meant to be a practice changing session. الحقيقة one is really fed up of hearing about colleagues and people dying. Just today there was in the news that 40,000 kids lost one of their parents in the UK. 40,000 children. This is a major catastrophe. I hope that my session today will actually change the way we deal with COVID-19 and really bring the mortality down very much. طيب these are the Sudanese heroes طبعا في بداية البانديميك. Right, my session will actually aim to empower the audience with the current effective therapeutic modalities based on systematic reviews of these interventions. We are actually obliged to use systematic reviews or findings from systematic reviews for treating or deciding in our patient management. I'm hoping that if we use all the proven pharmacological interventions, we could really bring down the mortality to zero or close to zero. Right. My talk is actually in two parts. The first part deals with how to deal with the moderate or severe COVID-19 infection, and the second part deals with the management of mild to moderate cases, in the community before coming to hospital. Right. I will actually go through very briefly about the challenge of COVID-19, some background knowledge, about EBM, evidence-based medicine jargon, because I'm going to mention some of these EBM technical terms, and people might not be 100% sure what these are for or what do they mean. So I'm actually going to explain this so that actually people could easily grasp the information that I will highlight afterwards, right? And then I will highlight these evidence-based interventions, and then I'll end up actually after the second part with the recommendations. Right? Just to give an example of the current status of COVID-19 epidemic in Saudi Arabia. And Saudi Arabia is really one of the few success stories in the world, actually, in the way they actually managed to control COVID-19. As of 4th of April, the number of cases were around 400,000, and the number of deaths were around 7,000. The case fatality rate is around 1.7%. And this is actually 22% lower than the rest of the world. There are various, statistical issues about is this really true or untrue, right? But on the whole, this is a measure of the great leadership this country is having, and also a measure of how good the quality of healthcare is like in the kingdom. Worldwide, 130 million people have actually 130 million cases are now have been recorded so far, right? With a staggering almost 3 million people dying, within the last year or so. uh, it's an unbelievable massacre. This virus is killing people, so much. More than 3 million people are already, almost 3 million people are already dead by the virus, right? Now, coming to the hospital rate, mortality rate, another staggering, statistics really. 1 in 10 people who come into the hospital actually die in the hospital, right? And almost half of those who go to the ICU actually die in the ICU, and this is really these are very serious numbers, and this is based on a systematic review and meta-analysis which was just published last month. Actually, most of my data are actually based on recent systematic reviews and meta-analysis. Now, there is some EBM jargon that I really should explain to you so that you could really grasp the data that I'm going to be presenting, right? I'll be mentioning something about what is meant by the evidence pyramid, uh, what is a systematic review, what's a meta-analysis, what do we mean by a forest plot, and how to easily interpret a forest plot. What does it mean to have something called network meta-analysis and grade tool? Now, these are important concepts. As healthcare providers, especially in the senior on at senior levels, we really need to be very conversant on this terminology. Terminology, right? So what's meant by the evidence pyramid? Now, in evidence-based medicine, there's a code that says not all evidence is equal. So we have evidence which is stronger than another one, right? And in general, in evidence-based medicine, something called systematic reviews and meta-analyses are considered at the top of the evidence pyramid, which means that these are the trustworthy evidence that we should be employing in our patient care, right? And following that, we end, below the systematic reviews and meta-analysis, we have randomized control studies and cohort studies, and therefore, when you say this evidence for COVID-19 are based on randomized control studies, then they are on the second level, and if you say these are based on cohort studies, then these are on the third level, right? But on the whole, systematic reviews are at the top of the level of evidence. So if I tell you that this evidence in COVID-19 is based on systematic reviews and meta-analysis, right? This is the top level of evidence. By all means, some systematic reviews are weak, some systematic reviews are strong, but on the whole, systematic reviews and meta-analysis are considered at the top of the evidence pyramid. Top of the evidence pyramid. Now, what is a systematic review? Just to simply explain it, supposedly we have a patient with hypertension, and we use beta blockers for hypertension, and in the beta blockers, we looked at the control of blood pressure, and so we have maybe 20, 30 beta blocking drugs or beta blocking drugs used in research studies, right? Some showed effective control of blood pressure, and some did not show effective blood pressure control, or some showed more side effects than the other, and so forth. So if I wanted to look at these beta blockers, so if studies are contradictory, right, which one should I believe? The study which says beta blockers are good, or the study which says beta blockers are not good for hypertension, right? So when people do systematic reviews, they go ahead and select and look at all the beta blocker studies in hypertension, right? And they use explicit criteria, right, to select the best ones of these studies. And they do something called critical appraisal to ascertain that these studies are actually trustworthy. And then they summarize the findings. So when they actually do this, this is called systematic review. They actually selectively choose the best beta blocker studies in hypertension, put them together, and come up with one conclusion. Right? Sometimes they use the same data and in these studies to reanalyze and get one result and to summarize the result. And if they reuse the data to come up with one conclusion, and this is then called a meta-analysis. So you can have a systematic review with or without a meta-analysis, right? Now, just to give you an example of how the data in a systematic review are usually summarized, okay? Now, this is a study which looked at the effect of steroids for relieving sore throat, the pain from sore throat, right? Now, when they summarize a systematic review for the use of steroids for relieving pain from a sore throat, they use something called the forest plot. A forest plot is just a graphical summary of what a systematic review is like. And it's actually simple to understand. Though it looks a bit complicated, but it's simple to understand. Now, they looked at the effect of steroids on pain at 24 hours and at 48 hours, right? When they draw a graph for a systematic review, it's called a forest plot, they have a vertical line. Now, this vertical line is usually the no effect line. So it means that this anything actually falling on this line shows that this intervention doesn't work, right? The vertical line is called the no effect line, and you can see it also here. And then on either side of the line, you have those which give positive or favors the treatment, and those which favor placebo, so it doesn't work. The intervention doesn't work. The horizontal lines are actually, each one of them actually, uh, you know, uh, is actually a study. Each one of them indicates a study, right? The square in the middle is the mean effect. The square in the middle is the mean effect. The bigger the square, the bigger number of patients, right? Now, the diamond is the meta-analysis, the statistical analysis of all these together put and are analyzed, and given the meta-analytic uh, diamond or result. Now, this study has the line, actually, the length of the line denotes the confidence interval. Now, so this is a confidence interval, this is a confidence interval, this is another confidence interval for this study, and so forth. One simple rule is that if a study has its confidence interval crossing or touching the no effect line, then we say that this study is not showing a benefit. While a study which is not touching the no effect line, that's to say far away, right? It's not touching the no effect line. It means that it has been effective, or if obviously if it is on the other side, it has not been effective. So in this study, you can see 4 studies, right? 2, this one and this one, are away from the no effect line, and therefore they are showing benefit. These 2 studies are actually touching the no effect line, and therefore they are not showing a benefit. So which one shall I believe? Then when they do the meta-analysis, they come up with a diamond, and it's away from the effect line, the no effect line. And then you come up with a conclusion just by looking at the forest plot that this the use of steroids is actually beneficial in relieving pain at 24 hours, right? Now, they did the same for a systematic review at 48 hours. Now, this time you have only 3 studies, not 4 studies. Now, 2 of them are actually touching the no effect line, and therefore they are not beneficial. But this study is not touching the no effect line, and therefore it's positive, right? It's actually showing a positive effect. The diamond is away. So now I can actually tell uh, with confidence that steroids do relieve pain at 48 hours, despite having 2 results which are negative. But this is a much more powerful study showing benefit, and the outcome is actually is positive. So it's important that people have this ability to actually, when they look at a forest plot, they straight away can tell this study is effective or not effective. And it's a very simple rule. If a study has a confidence interval which touches or crosses the no effect line, right, then it means that it's not beneficial. The intervention is not beneficial. Right. Now, coming to another important concept, because uh, we really have to use these high level studies to come up with conclusions on how to manage our patients. We really need to use evidence, right? The second concept is something called the network meta-analysis. So what is network meta-analysis? Now, in general, systematic reviews or look at the difference between treatment A and treatment B. But supposedly, if I have multiple treatments for hypertension, so I have uh, beta blockers, ACE inhibitors, ARBs, thiazide diuretics, calcium channel blockers, right? About other vasodilators. So which one shall I choose? Which intervention really gives me the best result, right? So this is the, to answer this question, people came with this issue, with this science called network meta-analysis, right? Or a tool called network meta-analysis, right? Now this is a study with six interventions, A, B, C, D, E, F. Now I can see that A has been compared to C, F compared to C, B compared to A, D compared to B, and E compared to B, right? Now, which one is really the best of them all, right? Now, the concept of network meta-analysis is actually very simple. It says that if I know how tall is C2 compared to A, right, and how tall is B compared to A, I can infer or come up with a suggestion of how tall is C compared to A. So actually, by direct and indirect comparisons, I could actually compare multiple interventions even when they don't have any head-to-head comparison, just by actually inferring from the studies and the treatment effects or side effects or magnitude of effect, right, between the different ones. So I know that C is taller than B, right? And if I know that B is also taller than A, I can infer that C is taller than A, right? So it's just a simple tool actually of comparing multiple interventions for any particular disease. So network meta-analysis is a tool actually for comparing multiple interventions simultaneously. And you analyze the studies and you make different comparisons according to the findings, right? The beauty of network meta-analysis, it can give us the full picture and it can rank the treatment. So I can actually tell, by ranking the treatments, which is actually good and which is actually bad. And I'll just give you a simple example, actually. Now, this is a meta-analysis, systematic review meta-analysis for interventions for the treatment of anxiety neurosis, right? Now, these people actually wanted to look what are the best drugs for anxiety neurosis. They looked at the literature. They finally got 46 randomized studies, 27 of them actually contain sufficient or appropriate data for inclusion in the analysis, right? And then they, at the end of the day, they came up with nine nine medications in these 27 trials, right? And you can see there is venlafaxine, escitalopram, duloxetine, fluoxetine. There is venlafaxine, 8 studies, escitalopram, 4 studies, duloxetine, 5 studies. There is a study between duloxetine and venlafaxine. There is a study between lorazepam and pregabalin, and so forth. So you can straight away visually tell how many good studies are there for the treatment of anxiety neurosis, right? And these people, when they looked at it, they came up with a conclusion that fluoxetine was ranked first for response and remission, and sertraline was ranked first for tolerability, and so forth. And you can straight away see the beauty of network meta-analysis, because for the first time, without having to look at head-to-head comparisons, you can come up with some conclusions that help you make the right decisions for your patient. Now, the last EBM, uh, terminology I have actually to enlighten you about, because it's used in actually looking at all the interventions for COVID-19, something called the grade. Now, the grade is a simple tool to assess the quality of evidence and to ascertain which one is really trustworthy or not. A very simple tool, okay? And they have a specific way of doing things, right? I don't have to tell you how is it done, but at the end of the day, when they grade the evidence, they come up with the certainty level, and they have 4 certainty levels. And this is important because when I'm actually going to mention the interventions that have been used in COVID-19, right, I'm going to indicate which one has had a high degree of certainty, which one has a moderate degree, which has low and very low. And you can easily see that High and moderate means that by all means you go ahead and use this level of evidence, this intervention. But if you see low or very low, then it's questionable whether you want to use it or not, depending obviously on your available resources, or if you have whether it's whether the patient likes to use it despite being of very low evidence. Very low evidence. Right. Now let's go to real science, right? And this is actually a publication which was actually published 2 3 months ago, right? Despite being published 2 3 months ago, still our management of COVID-19 did not make use of this evidence, unfortunately, and people continue to die. Now, the study is called, is the study title was Comparative Efficacy and Safety of Pharmacological Interventions for the Treatment of COVID-19, a systematic review and network meta-analysis. Now, PLOS Medicine is a high impact factor journal, so it's a trustworthy journal, right? They looked at all the pharmacological interventions that are used in COVID-19, which are mainly focused on patients with moderate to severe disease. That's to say, these are hospitalized patients. They were not interested in patients who were actually in the community, right? And they focused on randomized controlled trials. And interestingly, they also looked at observational or cohort studies. But these studies have to have confounding adjustment. It means that they have adjusted the result for the age, comorbidities, when the intervention was given, and so forth. So they had confounding adjusted observation studies, and it was only for people who are more than 18 years old, right? They defined moderate to severe disease. They classified the patients into two groups. Those with moderate to severe patients, these are the patients who were actually looked after in the ward. These were not actually ICU patients. And then a critically ill patient are the ones who went to ICU, whether they were ventilated or not. So they classified the patients into two groups, and they looked at the interventions at each group. Right. They also defined the dose for steroids. They said that they found that some patients, actually, some studies were using a dosage of 40 milligrams. This is called an average or standard dose of methylprednisolone or equivalent. And some used a higher dose, and these actually were labeled as high dose steroid groups. So they had two dosages of steroids, standard or high dose. Right. The outcomes of interest were actually five, and these were mortality, uh, whether the intervention stopped people progressing to severe disease, that's to say, needing admission to ICU or needing mechanical ventilation. They also looked at whether the intervention actually, helped clear the viral PCR faster, and they looked also at cardiac and non-cardiac complications from these interventions. Right. This is the literature search, found loads of studies, and obviously they found, COVID-19, more than 6,000 studies. And according to the selection criteria, they managed to get 110 studies, 40 of them were randomized, and 70 were observational studies. Right? On all, in all, actually, they actually had found that there are at least 47 pharmacological interventions that they are going to look at to see whether which one actually works. And in total, almost 50,000 patients were included in these studies. Patients were included in these studies. Right. Now, let's look at the first network meta-analysis graph, or actually image. The first one was actually for mortality for those in the non-ICU, right? Mortality for moderate to severe patients in the ward. Now, this big circle in blue is actually the control or placebo group, and these lines are actually telling us about the study. The thicker the line, it means that it actually mirrors the number of studies. Hydroxychloroquine plus azithromycin, you can see it's very thick line. So there are so many studies. High dose steroids, so many studies. Tocilizumab, so many studies. but you can visually see how many interventions. There are numerous interventions tried for patients in the ward, you know, to see whether right. So we have a big list of interventions. Now, when they looked at randomized control studies, initially, which ones actually reduce mortality in patients in the non-ICU, in the ward, you can, they only came up with two drugs, remdesivir and steroids. And you can see this one is for the steroids, and this one is remdesivir. Although in the graph it looks like it's touching the no effect line, as a matter of fact, it doesn't, because it's just, if it's touching the no effect line, it will be 1. But it is actually 0.98. And here in steroids is 0.91. So it's not actually touching the 1 or the no effect line. So in the randomized control studies, there are only two actually interventions which actually has, you know, proven to improve mortality in the world, you know, from control studies. However, when you look at also the other observation studies, and you can see that you have loads of other studies, other interventions, which also good, you know, which also has helped in reducing mortality in ICU in the world. In the world. I summarize it all here. You know, steroids, remdesivir. This is a drug for hepatitis C. Tocilizumab, convalescent plasma, interferon alpha. These are all interventions which seem to have worked in the world, right, to reduce mortality. But if you look at the grade, if you look at the grade, you see high, 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 moderate. So these are the ones which are really trustworthy. But if you come down to tocilizumab, convalescent plasma, they are lower grade, right? So you might say, well, shall I trust them or not? The very low are less trustworthy, right? But on the whole, you can see there are certain drugs which seem to have worked. Some are definitely effective, like steroids or remdesivir in the world. Now, if I go to the next part, right, what are the drugs which actually reduce mortality in the ICU, right? And again, you can see quite a few drugs being used to, quite a few drugs which have been used actually to improve mortality for critically ill patients, right? And you know, which one really worked, right? You can see there are loads of studies for tocilizumab, more studies, also studies because it's sick line for steroids. So you have actually several interventions which have been very trendy there. Now, mortality in the ICU, the only one that seems based on a control trial are steroids. So in ICU, steroids are the ones which seem to, based on control studies, are the ones which really work to reduce mortality. Others, like convalescent plasma and remdesivir, don't seem to work. It's very strange, right? Uh, why steroids here and not high dose steroids? It just tells that there is something there between these two studies. Maybe there is a difference in patient selection. But on the whole, you can tell that steroids seem to be the golden drugs for the ICU. And remdesivir doesn't work in ICU, right? And actually, that's the recommendation now. You use remdesivir in the ward, but not in the ICU, right? And when you look at randomized on the for observation studies, you get some more drugs which seem to have worked in reducing mortality in the ICU, right? And these are actually steroids, ivermectin, and tocilizumab. You can say that, okay, you can see that the steroids is a high grade, so very trustworthy, but also ivermectin and tocilizumab, right? And but the grade is low. So you want to trust it or not, this is up to you. But the one which you should really trust and you can say straight away, I'm going to use it without thinking too much, is the steroid. But tocilizumab, ivermectin, possibly high dose IVIG are effective in the ICU to reduce mortality based on cohort studies, right? Now, The third question is which drug reduces progression, which means that you started and then the patient actually does not progress and end up in ICU or dying, right? And again, you can see there are loads of drugs being tried, right, in to try to reduce progression, right? And based on randomized control studies, right, the ones which reduce progression is remdesivir and steroids. Again, you see, the only two drugs based on randomized studies which reduce progression are steroids and remdesivir. And we know that remdesivir works in the ward and therefore it stops people going to the ICU. It doesn't work in the ICU, right? If you look at cohort studies, a huge number of drugs which also reduce progression of the disease, right? High dose steroids, remdesivir, tocilizumab, convalescent plasma, and this anti-inflammatory baricitinib and anakinra. You know, people in rheumatology, I know that anakinra is available in Sudan, right? But if you look at the grade level is mostly for steroids and remdesivir, right? Tocilizumab is on the low side in reducing the progression, and also convalescent plasma, right? And the final thing is which drug reduces the PCR, makes people more likely to revert to negative PCR, right? Again, several drugs, some are actually being tested against each other, like hydroxychloroquine and lopinavir, ritonavir, right? But the only drug which seems to have increased viral clearance with a good and randomized control trial was the convalescent plasma, right? And convalescent plasma seems to have to work better in the ward rather in the ICU, right? But it does actually seem that convalescent plasma, but favipiravir, lopinavir, ritonavir, hydroxychloroquine, these are all failed to cause any major improvement in viral clearance, and loads of actually studies also based on control studies, based on cohort studies, right? There's nothing actually which showed that they're good in clearing the virus, right? So the only one really viral clearance is the convalescent plasma, but the grade level is on the low side. Again, questionable whether you want to use it or not, right? Right. Now, this is a very interesting conclusion. Um, you know, and actually, it was, the end to the saga of chloroquine and hydroxychloroquine and azithromycin, right? These are not effective at all. As a matter of fact, none of them singly or in combination worked in improving outcome in COVID-19. As a matter of fact, people should stop using azithromycin and stop using hydroxychloroquine, right? The good news is that they're not only not effective, but they also cause serious cardiac complications. The good news is that no drug was significantly associated with increased non-cardiac serious adverse events. So on the whole, most of the drugs that are now proven of benefit to patients with COVID-19 generally do not lead to serious adverse events, right? Now, the recommendations are as such. If you have a patient in the ward, moderate and severe patients hospitalized in the ward, non-ICU, by all means, you have steroids, tocilizumab, anakinra, remdesivir, convalescent plasma, right? This will reduce the risk of progression to severe pneumonia, going to ICU, admission to ICU, and mechanical ventilation. Added to that, these two primarily are the ones which improve survival. So corticosteroids and remdesivir used in the ward are the ones which will improve your survival, so you have less patients dying. Now, if you go to the ICU, corticosteroids are the number one. Yes, they reduce mortality based on randomized controlled trials, but there are others. Ivermectin, IVIG, tocilizumab also can reduce mortality, but they are based on observation studies, there were cohort studies. So these are lower level of evidence compared to the steroids, but yes, they are options. Forget about hydroxychloroquine at all. You guys stop using it. A very interesting observation actually from all this complex network meta-analysis study but it's worthwhile, highlighting that actually once patients go into the hospital, the drugs which really save patients are the anti-inflammatory, right? The only drug which seems to have an antiviral drug which seems to have worked in the ward is remdesivir, possibly convalescent plasma, but remdesivir, right? So when patients actually come to the ward, right, your focus is anti-inflammatory therapy, right? Plus minus some antiviral agent. Remdesivir is the one that seems to have worked. We don't have any evidence for other antiviral agents, favipiravir, ritonavir, all sorts of antiviral drugs, they don't seem to work. And this highlights the fact that the management of hyperreactivity of the host immune response, once patients get to the ward, should primarily be the target of our therapy. Once patients actually develop serious illness and they need to go into the hospital. And they need to go into the hospital. Right. Now, this is the first part, which dealing with moderate to severe disease, right? On the whole, when patients go into the hospital, right, your drugs are primarily the anti-inflammatory drugs. There is a mention that remdesivir is the one that works in the ward. Out of all the drugs that are possibly available, easily available in Sudan, which possibly can improve outcome in the ICU, is ivermectin. Uh, IVIG, I don't think it's easily available in Sudan at all. So ivermectin would probably not be there. Tocilizumab is also a possibility, but again, tocilizumab, like IVIG, doesn't probably, is not available easily. The only drug possibly with a low level of evidence that might work in the ICU in Sudan is probably ivermectin. But otherwise, all the others, uh, might not be available. So, in summary, moderate to severe disease, steroids are your mainstay of treatment, with possible some antiviral drugs, but antiviral drugs should possibly be provided to the patient early on when they are still in the ward before going to the ICU. The interesting thing is that ivermectin is an antiviral anti-COVID-19 drug, but it also has some anti-inflammatory effect. So I'm now going to the second part. Now, the second part is focusing on the treatment for the non-hospitalized patients. These are mild, possibly mild to moderate cases. But on the drugs which this particular network meta-analysis did not include for some reason or another. I'm not sure why, but possibly because there were not enough studies on them or because they were not for the moderate to severe patients. But there are studies for mild to moderate patients in the community, which I want to share with you. I want to share with you. So, so what is missing? We know that in COVID-19 is a phasic disease. So it's a disease which goes in stages. So we have a stage of viremia or a viral load, and then an inflammatory phase. And the viral of viremia is 0 to 5 days. By the end of the first week, people end up going into the hospital because they have this hyperacute inflammatory phase. Hyperacute inflammatory phase, right? And we know from the literature that you can actually divide these into 4 stages. Stage 1 is the viral infection with possible interstitial pneumonia the first week, right? And the majority of patients who need hospital admission will actually get admitted by the end of the first week. And then you go into stage 2 and 3, and stage 2 and 3 are actually not separate, but they come together. So they are both together. And one is hyperinflammation and hypercoagulability. And you can see in the network meta-analysis, there was no mention at all of anticoagulants in the network meta-analysis. And I think the primary reason for not being there because there are not many good studies which would fit to the selection criteria for their network meta-analysis, right? But then we really need to deal with the viral infection, the hyperinflammation, the hypercoagulability, the 3 components which actually As a matter of fact, most patients die of the hyperinflammation, hypercoagulability, and not from the acute viral infection itself, right? And every stage of this illness has its own, markers, right? It, the asymptomatic might be PCR positive or negative, but once they develop the infection, they start having pneumonia with PCR positive. They go into the hyperinflammation, and the marker for these are the high CRP, high ferritin, high interleukin 6, high LDH, and then they go into the coagulability phase when the D dimer starts rising up, irrespective of the CRP, right? And you get positive Doppler or pulmonary angiogram, and you start having multi-organ failure. So for every stage, you have its own markers, right? And you see the progression on the X-ray, the peripheral shadowing, which progresses with time in front of your eyes, and you get the CT with the ground glass opacification, primarily peripherally, interstitial change due to viral pneumonitis. Right. The three drugs which this network meta-analysis include, which are actually very relevant to our management in patients, are the anticoagulants, vitamin D, doxycycline, and possibly more data on the ivermectin, which the ivermectin, they found it only useful in ICU patients by reducing mortality in ICU patients. Now, let me just highlight what uh, the hypercoagulable phase in COVID-19. Now, this is again a very recent meta-analysis, only this last month, and they looked at 33 studies, and they found that on the whole, venous thromboembolism occurs in 9%, an unbelievable high figure for just a simple, just a viral infection. It's not a simple viral infection; it's a serious viral infection. But 9% of them, highlighting the pathophysiology of this serious viral infection. And if you go to the ICU, patients in ICU, 1 in 5 at least, will have DVT or pulmonary embolism. And if you screen, you get more. So the figure goes up the more you screen, right? And in the ICU, there is a high prevalence of thromboprophylaxis failure. That's what actually made people go for therapeutic anticoagulation when patients go to the ICU. Now, again, another systematic review, a pooled analysis. They looked at 5 observation studies. If patients were not given prophylaxis, almost half of them develop a DVT. And this is obviously a very high figure. But it just tells you how this disease is a hypercoagulable state. If you give them thromboprophylaxis, right, you reduce it, but it doesn't go away altogether. And similarly, for intermediate dose, you reduce it, but doesn't go away. And therapeutic, it is just suggesting that this pathophysiological mechanism is hypercoagulation is not 100% responsive to the anticoagulants we give, suggesting that there are some other mechanisms of hypercoagulability. And this is probably the reason why we see that despite anticoagulation, even therapeutic, these people still get thromboembolism, right? The interesting thing is that despite using therapeutic doses of anticoagulation or intermediate doses, there doesn't seem to be an increased bleeding risk, which is just a bit reassuring, but doesn't help a lot because we're still having this problem with hypercoagulability in our patients with COVID-19. And this was what has led, the guidelines are very inconsistent in the recommendations. I have seen guidelines saying that you have to use intermediate dose for ward patients, like 1 milligram of enoxaparin per kilogram, not the usual 40 for everybody, 40 milligrams for everybody. And there are some guidelines which say in the ICU you use therapeutic dose. You don't use only low dose. Right. Now, let's look at some studies, for COVID-19. Now, this is actually an observation study. They use intermediate dose. This time, they use anticoagulation and aspirin. So you can see that now we're not using only anticoagulants like heparin, but also aspirin. Now we're actually attacking the coagulation cascade in several fronts, that actually have led to lower cumulative incidence of any hospitalization. Can somebody mute the audience, please, because it's right.
Dear
Now,
audience, mute yourself, please.
okay. Now, in a small randomized study, in an observation study, a combination of heparin and aspirin really, seems to have worked. In an observation study, this is a small randomized study, and this randomized study is suggesting that therapeutic nexaparin does improve the gas exchange and decrease the need for mechanical ventilation in severe COVID-19, right? So there is a hint of benefit there, right? This is a very recent study, just last month again, and it's called the Inspiration Randomized Clinical Trial, big number of patients, and they found that intermediate dose prophylactic anticoagulation, unselected patients did not show benefit, right? And again, this is unselected, and we know that in COVID-19 we have to be very selective and in our intervention, and we have to look at the stage of the disease and then and look at the biomarkers and decide what is the dose of heparin we should use. Okay. Now moving from the heparins right to aspirin. Now the aspirin as an anticoagulant, this is a big retrospective study from the United States, right? Looked at people from 41 to 66, and they looked at people whether they were actually taking aspirin before or during admission. And they looked at the outcome, and they actually found that when aspirin was used, it was independently associated with decreased risk of mechanical ventilation, ICU admission, and in-hospital mortality. And you can see that adjusted is almost 50% less mortality in these patients who were used aspirin. Now you would say, okay, well, it looks fine, but this is a retrospective study, only one retrospective study. Okay, look again. Now, another study, which was also retrospective, also looking at patients who were given with an average age of 58 and who were actually on aspirin, right? They actually found exactly the same. Pre-existing aspirin prescription was associated with statistically and clinically significant decrease in overall mortality, cutting the odds of mortality by more than 50%. So another retrospective study looking at whether people were on aspirin or not. Now, the first study, they also looked at confounders, controlling for them, and the evidence was still there, right? Another study, another publication, right? February of this year. And again, they looked at participants, whether they are actually taking aspirin or not. And again, they came up that 30-day and 60-day mortality in the aspirin group were significantly lower than that in the non-aspirin group. Now, there is a noise there. There is a signal there, right? We don't have a randomized controlled trial, but we have several retrospective studies looking at patients who were on aspirin and suggesting that aspirin was actually better in does improve prognosis, reduce the death rate. Okay. Now coming up to another saga in the COVID-19 massacre we're seeing, right? Now, this is the NICE guideline. The NICE guideline from the UK says, do not offer a vitamin D supplement to prevent, and do not offer a vitamin D supplement to treat. Now, this is the NICE guideline, right? And, right, are we going to believe the NICE guideline? Well, now the second thing is, this is the American one, National Institute of Health. It says insufficient data to recommend either for or against. Now, when the National Institute of Health says that, it means that it's up to you. You want to use it, use it. If you don't want to use it, don't use it, right? Insufficient data for or against, okay? Now, this is about the vitamin D. Now, this is about the vitamin D. Now, let's look at vitamin D and COVID-19. And, looking at recent data, we don't want but recent data. Now, this is again just last month, a big systematic review, right? They looked at 43 observation studies. And what did they look at? They looked at vitamin D, the risk and severity of mortality, the association between vitamin D level and the risk of infection, the severity of the disease, and the mortality. And what did they find? that reduced vitamin D values resulted in higher infection rates. So people with lower vitamin D level are more likely to catch the infection, higher mortality and severity, right? They come with this, a logical recommendation. Okay, supplementation may be associated, may be considered as a preventative and therapeutic measure. Okay, this is just last month, right? But do we have evidence that vitamin D does actually might actually do something in COVID-19? We know vitamin D is actually a potent inducer of something called the cathelicidins. These are potent peptides which just destroy viruses. They just destroy the virus. They just attack the membrane of the virus and kill the virus. And they actually have some inflammatory, anti-inflammatory, anti-cytokine effects, and they've been shown to reduce the IL-6. Now, IL-6 is known to be a marker of severity, and that's why they use tocilizumab to improve prognosis, right? So vitamin D actually has been shown to reduce IL-6 levels, and based on previous studies, right? And the pathophysiology of COVID-19 and vitamin D deficiency, they actually mirror each other. Vitamin D deficiency increases IL-6, TNF, interferon gamma, just like what COVID-19 does, right? It's associated with increased coagulability. So theoretically speaking, if you give vitamin D, you might actually be, dealing with the COVID-19 pathophysiology, getting rid of it. Right? I'll just highlight 4 small studies. Now, this is a study which was a randomized study. So for people who actually say we need evidence from randomized studies, right? Okay, this is a randomized study, a randomized control trial, right? For non-hospitalized patients. These patients were vitamin D deficient. They were given 60,000 units per day for 6 days. And the virus was cleared faster. The inflammatory markers were less. Fibrinogen was significantly less, but CRP and D-dimer did go down in patients when they were given D-dimer. Another randomized study, another randomized control trial, this time for hospitalized patients, right? Some people had concerns about the randomization, but let's see the result, right? They gave calcifediol. Now this is equivalent to 25-hydroxycholecalciferol. The first step in the activation of cholecalciferol, right? This dose is almost equivalent to this dose, right? This dose of cholecalciferol is almost equivalent to this dose, 60,000, 70,000. Now, what did they find? They gave it in a several days, day 1, day 3, day 7, and then weekly. Look what happened to the ICU admission. The patients who received calcifediol, admission rate to ICU 2%. Those who did not receive, half of them went to the ICU, right? If you look at the table from this study, you can see the trend for CRP, ferritin, and D-dimer going down, right? Suggesting that vitamin D does have some anti-inflammatory effect, because you can see the trend in CRP, ferritin, and D-dimer going down, and with the vitamin D. Now, 2 very interesting studies came up, one from Britain, one from France. And they looked at patients whether they have been taking vitamin D before coming to hospital, right? And surprise, people who were taking vitamin D before coming to hospital were less likely to die in the hospital. And they were taking 20 to 50,000 international units weekly pre-admission, right? This is a British study. They actually looked at another cohort from another hospital and found exactly the same finding, that people who were taking vitamin D were less likely to die in the hospital. A mirror result from another cohort from another hospital, right? And this is the French one, right? They looked at patients actually whether they were taking vitamin D beforehand, and this was the dose they were taking. They were taking 50 to 100,000 every 1 to 3 months pre-admission, right? And they found less severe COVID and better survival. So again, strong signals that vitamin D might be good for actually COVID-19, right? But let me just highlight this negative study on vitamin D, right? And just tells you how it's important that we manage COVID-19 stage-wise, early on. We treat with the right drug at the right stage, right? Now, this is a study effect of a single high dose of vitamin D on hospital length of stay in patients with moderate to severe vitamin D, randomized clinical trial in JAMA, right? You can always find that the negative studies come in the big journals. The positive studies are not published in the big journals. You can straight away read why. Okay. Now, conclusions and relevance. These are people with moderately to severely ill, hospitalized patients. Average 10 days post-disease onset. They were given 200,000 units of D3 single dose, right? And they found no benefit at all. Neither length of stay, no mortality, no ICU admission, or mechanical ventilation. And they said we do not suggest use of high dose vitamin D. But they have to actually say that you are giving it late, at an average of 10 days, you are giving it to very ill people. Now, at this stage of illness, what do you need? Is it vitamin D or something else as well? Anticoagulation, do you need anticoagulation at this stage? Definitely. Now, have these people been given right anticoagulation? Were they given steroids to also attack the inflammatory response? Right. So this study was negative, and people actually thought that the dose was once instead of frequent, like the previous studies, which showed evidence, which showed benefit. So one dose is not enough. You have to give frequent doses. Don't give it very late. Don't wait until the patient is actually very ill. So don't do that. So this is a systematic review of many studies on vitamin D, actually 40 studies. 40 studies on vitamin D, right? And you can see most of the results were actually positive on the right-hand side, right? You give it early, you get better improvement. You give it late, you give it less improvement. And this is typical of COVID-19. You give the right drug at the right time, okay? And this is the no effect line. 0 is the no effect line. There are some studies which we didn't show much benefit because they are touching the no effect line, like this one, like this one. This one is touching the no effect line, but there are studies which were positive away from the no effect line, suggesting that vitamin D does work. As a matter of fact, they came up with this table saying that, if you give as a treatment, 73%. If you give it just a small dose replacement, the improvement is less. So you really have to give treatment doses, high dose vitamin D, right? 40 studies, in total, more than 300 authors, right? Right. Now, coming to the other one, doxycycline, right? I'm sure that many of you are actually maybe using doxycycline in treating COVID-19, but let's see that the evidence, right? Doxycycline was found to inhibit, the metalloproteinases, which are important actually, which allow viral entry into the cells, and they also inhibit interleukin-6, which can maybe ameliorate the cytokine storm. Doxycycline improves zinc entry into the intracellularly, and zinc actually in vitro is shown to kill the coronavirus. So has several potential beneficial effects. Now, there are at least 4 studies, actually there are more, but which suggest that doxycycline might be beneficial. The problem with these are small studies, mostly observation studies, right? Suggesting that doxycycline might be beneficial in patients with COVID-19. Now, look at the twist now, the big twist. Just again telling us what's happening in the COVID arena worldwide. Now, the principal study is a big UK study, and they looked at doxycycline and azithromycin in patients above the age of 50 to see whether they will actually reduce the duration of illness and hospital admission. So they offered patients in Britain above the age of 50 doxycycline or azithromycin. Okay, the study for azithromycin is already been published and it's no benefit at all. Right, so azithromycin is really out of the question for COVID-19. Right, now look what happened to doxycycline. Now they said that as per protocol, randomization into the doxycycline arm was stopped for futility due to small probability of a clinically meaningful benefit. They actually started seeing some benefit, so they stopped the study. Okay, now, so they stopped the study, and they said that according to the interim and incomplete data, there was a benefit in that people were less ill for they had a shorter time of illness, right, and a shorter less likely to be hospitalized. But they felt that the benefit was not strong enough to recommend doxycycline, right? So they said, okay, we don't recommend either doxycycline or erythromycin. That's the UK principal trial, right? They said that final results to be published. That was January, and until now the results are not published. Puts a big question mark. Why is the erythromycin study published, but not the doxycycline study? Really big question mark. Why are they doing that, right? Now, coming to the ivermectin one, right? The FDA say insufficient data, right? This was a change because initially they said we don't recommend. Now they say insufficient data. The European Medication Agency advised against, right? The Infectious Disease Society of America advised against use of ivermectin. We should not use ivermectin, they say. And the only one big group, international group, which is the Frontline COVID-19 Critical Care Alliance from America, they're warning world governments of the consequences of not deploying ivermectin for COVID-19. One big alliance of actually scientists, top line scientists in the world, right? Ivermectin works as an anti-inflammatory drug, but more importantly, it stops the virus from going into the cell. It stops it from attaching to importin, which is a protein which takes the virus inside into the nucleus. So it blocks this. So it has a potent anti-coronavirus effects, importin, right? And 35 studies for ivermectin, and this is the zero or no effect line. And you can see there are the diamond of the meta-analysis, 84% if you use it early, right? So if you use it early, you have better improvement, okay? And you can even use it prophylactically because it has shown that if you use it prophylactically, it can stop people catching the infection, right? So it can be used both preventatively and to prevent the infection in households, for example, or for hospital care workers. And also it can be used therapeutically, right? Now, they say we should not use ivermectin, okay? That was the recommendation. They haven't changed it. But will they listen? Now, this is a systematic review and meta-analysis of COVID-19, of ivermectin in COVID-19, March 29th, just last month, a week ago, isn't it? Around a week ago. The association between the use of ivermectin and mortality in patients with COVID-19, a meta-analysis, right? They found 6 randomized controlled trials, and this is the forest plot. The one here is the no effect line, and you can see that most of the studies are actually on the zero. Zero means that there is no mortality, right? And you can see it has all been on the left sides, right? Favoring actually a beneficial effect. And they said that we observed a preliminary beneficial effect on mortality associated with ivermectin used in patients with COVID-19. The pooled odds ratio is 0.21. Now, for people to appreciate what the pooled odds ratio of 0.21, it means that the mortality has been reduced by 80% or 79%, accurately. So mortality with ivermectin is reduced by 79%, right? Now, this is a systematic review meta-analysis. Just a week ago, I'll wait and see whether the guidelines are going to change, right? My expectation is they're not going to change because it's a cheap drug, and they want remdesivir, tocilizumab, right, to be used, right? They will not actually agree for us to use ivermectin, okay? And it works for prophylaxis. There are at least 4 studies in prophylaxis, right, suggesting that it does reduce the transmission in healthcare workers or households if you use ivermectin. So there is evidence that it does also can be used prophylactically, right? And this is the ivermectin, you know, systematic review meta-analysis. I just read you this: the probability that an ineffective treatment, like treatment with ivermectin, generated results as positive as the 35 studies to date is estimated to be 1 in 34 billion. A very unlikely that ivermectin is just a false drug. Okay, there are randomized control studies. You can say they are not very, there are some weaknesses, but which randomized control study is absolutely perfect? Okay, and they have shown that early treatment 84% improvement, late treatment 39% improvement, suggesting that it's probably the antiviral effect that's working more than the anti-inflammatory effect, and it's up to 90% improvement in success in reducing. Right. They have a recommendation for the dosages, like for ivermectin, 0.2 milligram. The general dose is 0.2 milligram per kilogram per dose, right? For prophylaxis, one dose today, second dose in 48 hours, and then every 2 weeks. Some people use, some studies were actually every 4 weeks, and it did work. And you can use it also post-COVID-19 exposure prophylaxis, 0.2 milligram per kilogram, then one dose today, and second dose 48 hours, and that's that. Right. For outpatient, you can use this dose, 0.2 milligram per kilogram per dose, one dose daily for a day or two, right? You can continue up to 5 days. For inpatients and in ICU, they increase the dose to 0.3 milligram per kilogram per dose, and you can use it daily for 5 days or for 2 days. Right. These are the recommendations of the frontline COVID-19 critical care alliance. Right. And lastly, I'll just finish with this combination, right? Ivermectin and doxycycline, right? We know that the combination is effective in some parasitic infections. So, is it working? Does it work in people with COVID? Because doxycycline, excuse me, also has antiviral, anti-inflammatory effect. So, is the combination possibly synergistic? Right? Now, there are 5 studies which used a combination of doxycycline and ivermectin and used outpatient and hospitalized. Outpatients, hospitalized patients, right? Double-blind randomized, case series, single-blind randomized controlled trial, okay? The general actually outcome is positive. You can see that 67% versus 44%, p-value is significant. 8 points deterioration, 8.7 versus 17.8%, right? Recovery time 5.9 days versus 9.3 days. All improved within 72 hours. Recovery time 6.3 versus 13.6. Mortality 0% versus 27%. Okay, right. Shorter hospital stay. Now, there are 5 studies. Some are randomized, and the signal seems to be strong. Right. Now, what are we going to do for our COVID patients to stop this, unbelievable carnage killing people all over the world? Right. Well, there is a statement which everybody must know, that you must provide effective treatment based on the best available evidence. Best available evidence could be a retrospective study, could be a case control study, could be even one single case report. If no better evidence is there, you use this one. Okay. Now, it's clear that we have, at this stage, we have possible vitamin D as a preventative treatment in those with no which are during the era of the pandemic. Vitamin D possibly has reduces the infection rate. So there is evidence for that. We know that we have loads of antivirals. Vitamin D is an antiviral because it clears the virus faster. And obviously remdesivir in non-ICU, interferons and so forth, convalescent plasma. The monoclonals, that's the one used for Donald Trump, which worked. We know that possibly ivermectin and doxycycline will work also as antiviral drugs. We have some evidence, good signals for ivermectin. not necessarily so for doxycycline, although the combination was highly successful, right? We know that we have anti-inflammatory drugs like steroids, vitamin D, tocilizumab, anakinra, parasitinib, and our anticoagulants, the usual aspirin, heparins. Okay. Now, in COVID-19, we have to treat the patients according to the stage. If they are in the community, we treat them differently from the ward, and we treat them differently from the ICU, because every one of them have a specific need. Every group have a specific need, right? Now, in the healthy people, by all means, you can use vitamin D, right? You might consider ivermectin prophylaxis for your healthcare providers. In the community, if they start to become symptomatic, by all means, there is good signal that vitamin D might work. Monoclonals we don't have in Sudan. There's no way we can use. These two have worked in the community, doxycycline and ivermectin. The combination of them, we have at least 5 studies which are showing a strong signal that they work. In the ward, the anti-inflammatory therapy is the primary thing, right? But we have to think in the ward of the anticoagulant therapy like heparin and aspirin, okay? Ivermectin, doxycycline, we have evidence for them in hospitalized patients, so they can also be considered, right? Once people go to ICU, the story is different now. Steroids, anticoagulation, possibly therapeutic. Tocilizumab, we have low-level evidence for ivermectin in the ICU, so ivermectin could still be there, right? But in Sudan, we have a problem with resources. We have really to use the resources we have, right? What do we have and we use, right? Limited resources. So in Sudan, in the community, by all means, all patients, let them take vitamin D. Hospital care providers offer them ivermectin if they are happy to use. Without anybody above the age of 50 with comorbidities, healthcare provider, tell them, come on, take ivermectin. It's a very safe drug, right? It is very rare to cause any serious side effects. Interactions are almost none heard of with important drugs, right? We don't want to see another, older adults, older, colleagues dying from COVID-19, right? In the community, when they become symptomatic, we have this triple therapy, vitamin D, doxy, and ivermectin. The evidence is already there, right? In the ward, vitamin D, prophylactic heparin, steroids, right? If they become hypoxic. Yes, by all means, consider aspirin, doxy, and ivermectin, right? The evidence is there. In the ICU, steroids, heparins, tocilizumab if you have, ivermectin, there is evidence for it, low level, but there is evidence for it, okay? But there is also the study in hospitalized severe patients with doxy and ivermectin, okay, which showed some benefit. Right, on the whole, just to conclude really, network meta-analysis is a useful tool for identifying and ranking effective pharmacological interventions. We really need to look at COVID-19 and treat according to the stage, right? Both preventatively and therapeutically, right? Antivirals are best for pre-hospital patients, and the 3 antivirals we can use pre-hospital are vitamin D, doxy, and ivermectin. And the anti-inflammatory drugs, primarily steroids, are the ones we use in the hospital or in ICU. Steroids. By all means, we can still use doxy and ivermectin. The current evidence-based pharmacological therapies actually should help significantly reduce mortality, especially in hospitalized. Right, and current evidence, with the current treatments, we should really be able to significantly reduce mortality. And it's very clear that we cannot treat COVID-19 with one drug or one intervention. We have to have multiple interventions to attack the multiple pathophysiological mechanisms, and we really need to develop tools to implement current evidence at the bedside. And with this, I really finish my talk. And if anybody has any question.
Thank you, Dr. Ahmad. Professor Ahmad, thank you for this. From where can you take this presentation?
I looked at mostly PubMed and systematic reviews. I looked mostly from PubMed. So you know, in my presentation, I included all the references. So by all means, you can check on them. But they are all systematic reviews from PubMed.
Professor Ahmad, thank you very much for a lovely, very comprehensive lecture. My question is the effect of those drugs on long COVID. Has that shown, is there any evidence that the drugs you mentioned had a positive effect against long COVID or not?
I'm afraid no. None of these interventions were actually for long COVID. They're all for the you know, the acute illness, right? But none of them were actually looked at their impact on long COVID at all. No.
Professor Ahmad.
مرحبا.
السلام عليكم.
عليكم السلام ورحمة الله.
Thank you very much, Prof. يديك العافية. Actually, very interesting and helpful, very helpful for us because we are in the middle of peak of COVID-19. يعني average patient in hospital not less than 40 for the last month. I have couple of things regarding anticoagulation. We have shortage in injectable fractionated heparin like enoxaparin. Now they provide the patients with only one injection every day. You need prescription. What about oral anticoagulation like rivaroxaban? Because it's available in the market. The other question regarding anti-inflammatory. All studies concentrating in steroids. Is there any studies in non-steroidal anti-inflammatories? Do they have any role? The other thing about remdesivir, it is expensive drug. It's not available in the country, but some people nowadays bring it from outside, from Emirates, namely. And I noticed in the vial itself, because when I talked to the Emirate doctor there, I asked him to provide that with a prescription and this stuff. They actually is not in the vials are in big box, no leaflet, no pamphlet, nothing, and it's written in the vial itself. It's for clinical trial only, and the other word for guidance of use and reconstitution, they ask you to go to clinical trial protocol. And the last thing caution from USA is this drug is limited for investigation use only. This is written in the vial itself. I do appreciate that it have evidence, especially in mild to moderate hospitalized cases, but these warnings in the vial itself actually worries me a lot. So if we spread such knowledge, people may think they should have it. This expensive drug in the country and included in the protocol. And really, I'm not 100% satisfied that's okay because of this sticker on the vial. Ivermectin, we do not use it. It is cheap. I think if we talk to authorities here, they can include it in the protocol. Regarding anticoagulation, in the last session, you talked about the D-dimer. This time, you didn't talk about it as if it should be universal for all patients. Is that right, regardless of their D-dimer? Thank you very much. I have a couple of questions, but the electricity here is
مرحبا
off, and
مرحبا يا أستاذ.
I wrote some things, but if I remember, I will call you again.
Okay. The new oral anticoagulants, unfortunately, I haven't looked at specific studies for the new oral anticoagulants. I must say. I haven't come across it actually. But maybe there are studies on the new oral anticoagulants, and they are possibly, if you are really, you don't have heparins or the low molecular weight heparins, the unfractionated or low molecular weight heparins. By all means, you might end up having to use them, especially if you can confirm that the patient has a DVT or a PE. But I haven't come across any study specifically looking at the new anticoagulants, new oral anticoagulants for COVID-19. By all means, D-dimer should be done. Serial D-dimer is very important in monitoring these patients, just like the CRP. CRP and D-dimer are the two primary biomarkers you should really monitor the patients with. The remdesivir issue, most likely the patch you are getting actually is an old patch, right? But now remdesivir, the systematic reviews are very clear that it does actually improve prognosis in patients in the ward. And 5-day course is as good as a 10-day course. But it is now part of the usual protocol in the States, just like the monoclonals are given in the outpatient and the remdesivir in the inpatient. That's what the Americans are doing at this stage. But I suspect what is written in the patch is actually because it's an old patch before the evidence, so everybody was just trying to use it in just trying it. But the evidence now is really strong that it does actually improve outcome. Right. Any other question I missed?
I think that's all
Yeah,
actually.
the ivermectin thing. I think whenever you have some evidence, be it low level evidence, as long as there is some evidence, the drug is cheap, it's safe, the patient doesn't mind having it, the benefit really outweigh the harm. The benefit really outweighs the harm. And then and you have a patient who's actually all the risk factors for dying from a COVID. Somebody he's 60, he's hypertensive, he's got significant other comorbidities, right? And gets a COVID, the lungs are bad, and he comes to you in the first week and you say, I'm not going to use it because the low level of evidence, and you wait until he dies or she dies, right? So it's important that people use these things using just the basic EBM criteria, best available research evidence, harm, benefit outweighs harm, availability, patient values and preferences are okay, the patient doesn't mind taking it. The side effects from ivermectin are really very rare. Okay, just like vitamin D, the side effects are really very rare.
And the doses, usual doses is?
Yeah, most of the studies use the single dose, 0.2 milligram per kilogram, one dose only.
One dose.
One dose only, but some people use 2 doses, a minimum of 2 doses. And in ICU, they go for 5 doses, right? The drug is an extremely safe drug. It stays in the body. Its half-life is sometimes, 36 hours, and it stays in the body. It's not a drug which is cleared very fast. Right.
May I use your lecture to publicly aware people about not using azithromycin, because we have really many patients came to us with serious conductive issue in form of bradycardia, severe bradycardias and heart block, and it was really serious. And still people use it in almost every patient. And we need to make them aware that there's no evidence supporting using azithromycin or chloroquine and this stuff, if you give me the permission.
Yeah, no, I'll pass the whole presentation. I'll pass it to you in the group. Yes. Any other question at all?
السلام عليكم.
مرحبا دكتور زينب.
Thank you for this informative presentation. I have one question regarding the desaturated patient on COVID and no other symptom. Maintain oxygen on 2 liters only. and almost complete 2 weeks of all this evidence-based protocol. I don't know for how long we can continue on this protocol after this. Patient is if he, patient is still desaturated, and any evidence base for other than steroid can use in this case.
Well, beyond the first week or 10 days, right? Then apart from steroids, the second step is the anticoagulation. Beyond the first week, steroids and anticoagulation. Obviously, there are chances of secondary bacterial infection, and that's why we say, by all means, try doxycycline as an antibiotic because it might work in both the COVID and the secondary bacterial infection. But in pulmonary embolism, by all means, is a possibility. We have seen patients actually who keep this desaturating because they have developed significant actually fibrotic changes in the lungs, interstitial damage. But steroids, anticoagulation, covering for secondary bacterial infection. If you have the facility to do D-dimer, check the D-dimer. If it is high, by all means go for a pulmonary angiogram or a Doppler of the legs or an echocardiogram looking for pulmonary embolism. So if you find a high T-dimer within desaturating patients.
We can continue on this until the patient become undesaturated or what?
إذا عندك مثلا if you are anticoagulating the patient مثلا you are giving him therapeutic dose of heparin, right? By all means keep him until you exclude pulmonary embolism, and keep him on a therapeutic dose on suspicion of pulmonary embolism. Lano, this is what kills these people, right? If you have no contraindication for therapeutic anticoagulation, by all means use therapeutic anticoagulation and try your best to exclude the PE. And you have 3 ways of excluding a PE. If you have a facility to do pulmonary angiogram, that's good. If you have a facility to do an echocardiogram, that can also help. Or you can do a Doppler of the leg, because in at least half of patients with Okay, any other question at all?
Yes, دكتور عماد السلام عليكم جميعا.
مرحب دكتورة نهلة.
الله يسلمك. Very informative session, and I'm happy that like it is an update. If we do have clinical trials which comes data for 1 week back, that means every day we have a new update. So that is like alarming, not to depend on one protocol for a long time without updating and revising for the treatment. My questions regarding the efficacy of the medication. Can you hear me?
أي لا اتفضلي يا دكتورة نهلة.
ألو؟
أي تفضلي يا دكتورة نهلة تفضلي. We can hear you.
ألو؟
أي تفضلي يا دكتورة نهلة.
كده سامعني؟
أي سامعينك.
Okay. The question regarding the efficacy. Okay. Efficacy of the medication in relation to the variant. Is there any study done?
أيوة والله an excellent question. طبعا أنا I was looking at these. The 4 variants اللي موجودين في العالم غير الفاريانت الأولاني كويس، ما عندنا study على الفاريانتس الجديدة كويس. we are hoping إنه the studies اللي اتعملت على old variant أو original variant will still work on the new variants. يعني الستوريز حقت الايفرمكتين والدوكسيسايكلين دول كلهم لهم 6 شهور و9 شهور، تمام، قديمه شويه. اوكي، لكن we are hoping that they are still going to be working. Okay, ما until we get evidence to the contrary, we just have to continue using them لانه ده الحاجه الافيلبل المتاحه.
السلام عليكم.
مرحبا دكتور تسابيح.
Thanks, Dr. Ahmad, for very informative presentation. My question is also regarding anticoagulant. I have two questions. First question, I saw KSA protocol. They mentioned do not offer a therapeutic dose of Clexane unless there is evidence of BE. The protocol mentioned use 40 milligram OD. If a body mass index more than 40, use 40 milligram BD. I'm working at isolation center. Really, I observe some patient had DVT or BE, or some also has bleeding. For which is best, therapeutic dose or prophylactic dose? This is my first question. My second question, the secondary bacterial infection أكيد قاعد يحصل, but in some cases we have negative culture result repeated many times, but all inflammatory marker are rising. What's the exact, or what is the proper action to do with this patient? Thank you.
طيب مشكور يا دكتور سامح. طيب بالنسبه للانتي كواجوليشن الحقيقه في lots of controversy, في guidelines تختلف من مكان لمكان. In general patient hospitalized تديه ال usual recommended dose. Okay, as the patient gets worse or desaturates or goes to the ICU, you have to go to the therapeutic dose لغايه ما تعمل exclusion لpulmonary embolism. يعني البيشنت اللي اديتيه بروفيلاكتيك تمام by all means you know just monitor their D dimer. لقيت الدي دايمر طالع كويس you might have to increase من ال 40 ملغ ل 1 ملغ per kilogram. راح الاي سي يو then you have to consider therapeutic و to do a spiral CT او ايكو او دوبلر اوف ذا ليجز عشان تتاكد في كلوت ولا ما في كلوت. لكن المونيتور بتاعك اللي بيخليك تو ابجريد هو الدي دايمر. السؤال الثاني السؤال بتاع increasing CRP وسكندري بكتيريال انفكشن. طيب هم بيقولوا انه السكندري بكتيريال انفكشن in COVID-19 is unusual, يعني the majority of patients will not develop secondary bacterial infection. الماجوريتي. طب ليه السي ار بي بيطلع؟ السي ار بي بيطلع is just a marker of the COVID inflammation. والعلاج بتاعه الستيرويدز. تمام؟ انا كان في الاول قدمت الكيس اللي قدمتها لكم الفيرست كيس اللي قدمتها كويس. اول ما بدينا له ستيرويدز السي ار بي بتاعه نزل طوالي كويس. والستيرويدز في كوفيد 19 اذا اديت ستيرويدز والسي ار بي نزل معناها يو ار رايت. اذا لقيتيه طالع بعد ده شك في السكندري انفكشن كويس. ولقيت السي ار بي طالع مع الستيرويدز think of secondary infection و think of pulmonary infarction لانه ديل الحاجتين اللي بيرفعوا لك السي ار بي ومع مع الانتي انفلاماتوري ثيرابي اللي انت بتديه. والمريض اللي احنا قدمناه زمان ذاك احنا كان اديناه ستيرويدز وبدينا له دوكسيسايكلين معاه تيزوسين اللي هو الكومبينيشن اوف بيبراسيلين تازوباكتم والسي ار بي بتاعه طوالي نورمالايزد يعني الكومبينيشن اوف دوكسيسايكلين اند ستيرويدز. لكن العالم كله الان السي ار بي الهايبر انفلاماتوري ريسبونس والسي ار بي اللي بيجي مع الكوفيد 19 is steroid responsive. اول ما تدي الستيرويدز لقيت السي ار بي نزل معناها you are in the right track. سي ار بي ما نازل معناها there is something else. اوكي يا عندك secondary infection يا عندك infarction كويس pulmonary infarction يعني look for other causes of اللي هي السي ار بي not normalizing.
يا بروف لو سمحت لي في اوبزرفيشن. نحن الناس عندنا بيقعدوا فترات طويله معانا في الاي سي يو 20 days 30 days sometimes up to 2 months بيكونوا in the ward. لقينا انه يعني we notice that انه after 10 12 كده الناس ديل they start to pick up again الوايت سيل كاونت والحاجات دي ويعني عندهم secondary bacterial infection في الغالب، و sometimes fungal يعني they grow some candida in the blood وكده. فهل ده related the length of steroid use؟ يعني الكورس بناخده الدexamethasone ده زي 10 days كده. ف what do you think يعني؟ لانه دي هسه بقت real problem، ودي بقت تعمل لنا المشكله دي بتعمل لنا deaths يعني السكندري بكتيريال انفكشن.
هو طبعا عموما الشورت كورسز اوف ستيرويدز يقول لك يعني ما بتعمل سيريس انفكشن شورت كورسز، لكن احتمال الانتوبيشن والسيت اب بتاع الاي سي يو هو اللي بيجيب الانفكشن، يعني مور ذان ذا ستيرويدز. لانه يعني مثلا انا المرضى بتاعي اللي اديناهم عندنا في المستشفى مثلا 6 ملي جرام ديكساميثاسون فور 10 دايز وما مشوا الاي سي يو، ما لقينا. فهو المشكله السيت اب وليس الاستيرويد. السيت اب هو اللي هو
وي نو طبعا انه ذا ريسك اوف
ايوه. فهو البروتوكولات حقت ريديوسينج اللاين سيبسيس والفاب في الاي سي يو، دي البروتوكولات اللي انت محتاج لها. مش السبب الاستيرويدز، مش السبب الاستيرويدز، لا هي السيت اب هو اللي فيه مشكله. السيت اب هو
عندي اضافه لك يا
سالتك برضه عن
طارق.
النون ستيرويدال.
ايوه النون ستيرويدال ما في evidence supporting its use. لا
في اضافه
بالعكس، هي في الاول شكوا انها هي makes the outcome worse.
مات
تفضل يا دكتور نهله، تفضل.
as انه كنت طبعا head of department للاي بي سي during الكوفيد 19 في البيبل الاولى في يونيفرسال هوسبيتال كايسوليشن سنتر. فكانت المشاكل اللي بتكون في الاي بي سي الاسوشيتد في الاي سي يوز غير انه نوت ريليتد. ما عندنا ستيل طبعا العالم كله ما عنده بروتوكول للانتي ميكروبيال ريزيستنت، لكن المشاكل الاساسيه كانت هي ما عندنا روتين check if there any opportunistic infection. لكن الاساسيه كانت بتكون دائما من التيوبينج، من السنترال لاينز، اللونج intubations، دي النوت بروبر كير of the catheters. كان الكاثيتر associated infections هي كانت common، وانا افتكر دي مشكله رئيسيه الان موجوده في كل الاي سي يوز في السودان. يعني حتى النيونيتال اي سي يوز ستيل دي كل المشاكل الموجوده تعمل لنا secondary infection، يعني بيكون ما في efficacy من الانتيبيوتكس.
هو طبعا في عندك انت حاجتين الحاجه complementary. واحد انه يكون عندك توب ليفل انفكشن كنترول بروتوكولز، يعني هذا واحد. والحاجه الثانيه عندك افيلبل انتي بايوجرامز. فالمشكله افيلبل ذا مايكروبيوم اللي هو الميكروبيولوجي بتاعت الاريا والانتي بايوجرام بتاعها، عشان انت تكون عارفه البروتوكول بتاعك هيمشي وين لو جاك انفكشن. ولكن انا افتكر الانفكشن كنترول بروتوكولز هي الاهم. how to reduce الفاب، how to reduce اللاين سيبسيس، اللي هي البروتوكولات حقتي هي اللي بتقلل. ومشكله الانتي بايوجرامز دي انا عارف انه في ناس عندهم publications على الانتي بايوجرامز، يعني فبيعرفوا يعني they know exactly what organisms. مثلا كان الدكتور طارق الهادي في فضيل كان عندهم انتي بايوجرام.
نعم. دائما نحن في السودان عندنا مشكله ما في مايكروبيولوجيست معنا، لكن كانوا يشتغلوا معنا اثنين كالفارماسيست، وعملنا شغل حلو هاي في انتي بايوجرام في فضيل وكده. لكن انت بتحتاج لمالتي سنتر داتا عشان الحكايه دي تقدر تعملها يونيفرسال في البلد وكده، دي مشكله يعني. لكن فعلا الكير اوف لاينز والكاسيتارز والهناي ده الناس بيشتغلوا فيه، لكن هو فعلا ما زال مشكله يعني. انا بس لانه لاحظنا الحكايه دي بتجي بعد دقيقتين، يعني بعد دقيقتين تلقى الوايت سيلز جامس تو 20 و30 وكده، وتفتش العيان كويس والله تكون تشينج واي حاجه، وبرضه ديسبايت ذات ما يعني you lost the patients. مشكله يعني، لكن بنخلي بالنا من الحكايه دي ان شاء الله.
هو المفروض يكون في how to which antibiotics to start with and how to monitor a response and escalate، يعني when to escalate to مثلا to antifungal at one stage. ايوه في
الانتي فانجل not common in our practice. انا ما اعرف دكتور كمال شايفه attending he can comment also. لكن الانتي بايوتكس نحن we upgrade يعني
السلام عليكم.
مرحبا دكتورة.
أيوة دكتور. I'm asking also about the procalcitonin. Is it reliable if it is negative to exclude the secondary bacterial infection? And what about the use of antifungal like fluconazole? If my all inflammatory marker is getting rise, my culture negative, I will cover with gram-positive and gram-negative infection. Sometimes we use fluconazole or antifungal coverage. What about that? And what about procalcitonin?
طيب البروكالسيتونين سبحان الله يعني أنا my experience أنا الحقيقة ما didn't look in the literature لكن my experience إنه البروكالسيتونين does really go up مع الكوفيد يعني مع إنه هو ما بكتيريال انفكشن هو فيرال انفكشن لكن البروكالسيتونين كان increase dramatically معاه و we still treated with steroids يعني هو CRP we treated with steroids لكن طبعا لانه دائما احنا عندنا الشك بتاع secondary bacterial infection we tend to actually you know add antibiotics broad spectrum antibiotics في البروتوكول when to add الانتيفنجل يعني عملت good bacterial cover the patient is not improving في major risk factors لل candida او fungal infection عندك الفنجل لود از هاي يعني patient عنده كانديدا في لما ياخذ في الفم كويس ولا عنده كانديدا في السكين ولا عنده بريتش في السكين وسنترال لاينز في الحاله دي يعني بيبقى كرايتيريا فور كفرنج الانتي فنجل هاي الكانديدا يسموه الكانديدا لود او الفنجل لود في المريض يعني عنده multiple areas فيها candidiasis او fungal infection and then the antibiotics, the antibacterials are not working, so you add the antifungal. Based on طبعا you can request the blood cultures. وعادة if it's positive, it's just treated straight away.
مساء الخير يا بروف.
مرحبا يا أحمد، كيفك دكتور أحمد؟
الحمد لله الله يخليك. أنا الكومنت بتاعي يا بروف as my colleague before mentioned إنه البيشنتس هنا staying في السودان الICUs وحتى في الورد for long time يعني more than 15-20 days. and I think إنه إحنا محتاجين ل road map أو fixed guideline بالنسبة للأبيوز of antibiotic. في أنا الحاجة شايف إنه ممكن مرات بس زي abuse يعني في some antibiotics can be used more than 14 days وبتجي الكلتشر several times negative. اغلب الناس بتعتمد في الاي سي يو على زي ما قلت تفضلت قبل موضوع السي ار بي والوايت بلاد سيلز يقول لك الوايت بلاد سيلز هاي والسي ار بي هاي فما اعرف هل في جايد لاين فيكس للموضوع ده لانه انا الحاجه شايف انه في زي ابيوز يعني 14 دايز فينيشد اوكي جروث ما في جروث سي ار بي ستيل هاي وايت بلاد سيلز هاي يقول لك لا ابدا بعده ثاني ابدا نوع ثاني من الانتيبيوتيك مرات بيستمروا اكثر من كم 20 دايز ما اعرف عليه
هو طبعا يا دكتور احمد الحاجات دي المفروض بيحكمها البروتوكول في الوريبر اليونت يعني في الهوسبيتال في بروتوكول وفي هو الانتيبيوتيك ستيوارد شيب وزي ما قال الدكتور طارق you really need a microbiologist on board either infectious disease specialist or microbiologist عشان هم to stop using الانتيبيوتيك stewardship to reduce الاوفر والمشكله الاوفر يوز انه وفعلا زي ما بيحصل تلقى الوايت كاونت زاد والسي ار بي زاد قالوا انفكشن طبعا في people have to look for other causes of a high CRP high white count يعني these are both of them are very low sensitivity for bacterial infection there are so many causes of high CRP and white count حتى الاستيرويدز اللي احنا بنستعملها دي الدكساميثازون ده بيرفع لنا الوايت كاونت يعني اساسا leukocytosis is part of the side effects of steroid use. I should not rely on the leukocytosis في مريض بياخد steroids as a sign of infection لأنه أساسا this is a side effect of the steroid. I shouldn't. I should be looking at microbiology of the patient, looking for other causes of an increased CRP. Okay. وزي ما ذكرت لك يعني ذكرت قبل يعني steroids in COVID bring the CRP down. كويس. This is a sign of response. If a patient CRP does not come down with the steroids, these patients are likely to die. But you have to look for other causes for the high CRP. وفعلا في study just published يمكن قبل أقل من كم يوم، يومين ثلاثة. People who drop their CRP fast على steroids, they do very well. People who do not drop their CRP fast by at least 50% within 48 hours على الsteroids, معناها there is something wrong. These patients are likely to die. عشان كده monitoring a CRP with D-dimer on these patients is very important. You cannot do without CRP and D-dimer monitoring to know where you are heading, right? Steroids drop the CRP, fine. D-dimer طالع, man, I have to look for thrombotic, for hypercoagulability thrombotic episode. فمهم جدا. فمونيتورينج وانتيبيوتيك stewardship وفعلا stopping الاوفر يوز. يعني في اللودز، يعني الايزيثرومايسين الان everybody is using erythromycin مع انه evidence is now very powerful against it.
السلام عليكم يا بروف.
مرحبا دكتورة سوزان. مرحبا.
الله يسلمك. داير اسال عن الرول بتاع الانترلوكين 6. أنا I'm working في ICU for COVID patient. They are giving the drug Anikra. ما عارفة بروناون صح ولا لا.
هو أيوة أناكينرا.
يس. لكن يعني كل البيشنت البروتوكول بدهم كل ده، لكن يعني ما شايفة يعني في تحسن بيكون في واضح فيهم كلهم إنهم مبروفين، كلهم ما زالوا على الميكانيكال فنتيليتر وقاعدين كم 20 يوم. فما أعرف هل فعلا إنه الانترلوكين 6 هي effective؟
ولا هو الأناكينرا هو يعني ما بيشتغل في الاي ال 6، ما له شغل انا بالاي ال 6. لو عايز الدراكس بتشتغل في الاي ال 6 كويس، اللي هي يعني هي الدوكسوسايكلين بيشتغل في اي ال 6 يعني معروف. حتى المترونيدازول التوسيلوزوماب طبعا هو البرايمري انتي اي ال 6. لكن طبعا انا بتكلم حاجه في السودان. لو عندك توسيلوزوماب باي اول مينز. الاناكينرا ما بيشتغل على الاي ال 6. توسيلوزوماب دوكسوسايكلين عندنا ايفيدنس انهم دير اساسا عندهم ايفكت على الاي ال 6. بعدين بالمناسبه الحبه السوداء في ستاديز ورت انها بتنزل الاي ال 6. ليه احنا ما بنستعملها؟ فيها ضرر؟ ما فيها ضرر، يعني ما تضر حاجه. فالاي انتي اي ال 6 لو توزيلوزوماب ما في توزيلوزوماب جربي دوكسيسايكلين. الحبه السوداء اذا البيشنت كان تيك اورالي give him good dose of الحبه السوداء. It has an anti-IL-6 benefit. لكن في حاجه مهمه. المشكله عندنا احنا في الاي سي يو وي اتاك ويز، اذا كان ادينا مونوثيرابي عشان نعالج المريض ما بيصلح. You have to have multiple interventions، يعني anticoagulation, anti-inflammatory, possibly antiviral, although not as effective في الاي سي يو compared to early on. يعني انت ما ممكن تعالج المريض ب one modality بس. انت عايز تعملي multiple modalities عشان to help the patient.
Yes, thank you.
Dr. Ahmad?
مرحبا.
I'm asking also if there is any evidence for dexamethasone dose more than 60 mg OD. Some practitioners prescribe dexamethasone 8 hourly. Is it any evidence for this dose?
عفوا معليش انا ما سمعت سؤالك ثاني معليش.
dose of dexamethasone.
ايوه هم الايفيدنس طبعا بيز ال 6 ملغ بس ما في ناس في الهاي دوز اللي بيستعملوا اكثر يعني. لكن الدوز الان الانترناشونال اكسبتد 6 ملغ اوف دexamethasone. دي الدوز الان اكسبتد. وفي ناس بيقولوا انه possibly ديكسا احسن من البريدنيسولون واحسن من الهيدروكورتيزون، لكن كلهم alternatives اذا ما لقينا دexamethasone.
For asthmatic patient, can I use it instead? Can I use it? Asthmatic patient, I think مثال prednisolone and hydrocortisone.
ايوه you can use
be
dexamethasone.
better.
it will work. ما هيشتغل تمام في
No
الازمه.
problem.
يشتغل في
Okay.
الازمه.
Okay. Thank you.
Right. The time has run, and if there are no more questions, we thank you all really for your attendance, and I hope you can make use of the information in this presentation to help more people and stop people from dying from COVID-19. مشكورين كل الحضور. بارك الله فيكم. شكرا جزيلا.
Thank you.
شكرا. بارك الله فيكم. شكرا.
Thank you very much. Very interesting. Thank you very much يا برو.
مرحبا بك يا طارق. مرحبا يا دكتور طارق.
لو في حاجة أنا برجع عليك.
مرحبا بك أي وقت والله يا طارق. مرحبا بك أبدا دائما.
الله يخليك. كتر خيرك يا برو. أيوة مفيدة جدا.
الله يسلمك. شكرا لك يا طارق. شكرا لك.
الحمد لله.